Thank you very much for the introduction. Next page. Should I? Okay. Oh, sorry. So far, the incidence of the patients with corroded chronic total occlusion in the population, especially in the eastern countries, is still unknown. But some of them are asymptomatic. They are facing a significant risk of stroke. So who are the right people to need to do the corroded endovascular recanalization? It's a big question, but technically, endovascular recanalization in the patients with corroded CTO has been reported to be feasible, but still challenging. So for our radiologists, we have to face with the question is that how to increase the successful rate by preoperative imaging. Clinically, ultrasound, CTA, MR-VWI, and DSA are commonly used for the detection and evaluation, but these angiography modalities were unable to characterize the occluded segment clearly or directly. However, the 3D MR-VWI imaging has the ability to directly visualize both the inner and outer wall of the carotid artery and can cover the whole occluded segment as well. So, and we, in our previous study, we found that 3D MR-VWI it has had a very high sensitivity and specificity to qualify the carotid occlusion when we compared with the DSA. So in this study, we aim to evaluate the pre-procedure 3D MR-VWI imaging in the patients with the internal carotid CTO and investigate its relationship to the revascularization success rates. And we included the patients who were diagnosed with internal carotid CTO by MR-VWI. And if the patients with the recent or recurrent ischemic symptoms or with the corresponding hemispheric hypoperfusion, and these patients are recommended to perform the subsequently DSA and endovascular recanalization within 1 week of the MR scans. And the 3D MR-VWI images were acquired to use a very fast blackbud 3D merge sequence on a clinical 3D scanner with a head and neck coil. And the morphological characteristics, including the occluded segment distribution, proximal stump condition, distal true lumen visibility, and the presence of high signal intensity of the lesion were recorded on the MR-VWI images. As for the occluded segment distribution, we use the C1 segment as the landmark and divided these lesions into the occluded lesion within the C1 segment and over the C1 segment. And since the proximal stump condition is closely related to the guide wire or catheter to entering the true lumen, so we categorize the proximal stump condition into 3 types. A is tapered stump, B is blunt stump, C is no stump. And the distal true lumen visibility in the C1 segment was recorded, and the presence of high signal intensity, these lesions, these high signal intensity, the etiology may differ. They may be indicating the intraplaque hemorrhage, maybe the hemoglobin lesions like dissection or blood clots. The left side is the segmental high signal intensity lesions, and this is a diffuse high signal intensity lesions. And the endovascular DSA and the recanalization was performed according to the standard procedure. Here is our initial results. We included 38 patients. Most of them are male patients, and they are selected to perform the angiography and attempt for the endovascular recanalization. And in this table, you can see compared with the failure group, the success group has less prevalence of occluded distribution of the C1 segment and high prevalence of the high signal intensity of the occluded lesions. Let's see some cases. It's a 59-year-old male patient with the right chronic total occlusion. You can see there's no stump at the start of the internal carotid artery, but the segment is very short and the distal lumen is clearly seen here, and the vessel wall is smooth, but you can't see on the DSA. So we strongly recommended the neurosurgeons, you should try, and if you can go through this occluded segment, it will be successful. So he tried, and finally he made it. This is another case, 64 years old. It was diagnosed left internal carotid occlusion by the CTA. There's a blunt stump here, but we can't tell what's going on of the occluded segment. So we did the MR-VWI imaging. We can see there's some true lumen here, black area here and here, and some scattered high signal intensity lesions in, on the vessel wall or in the vessel wall, in the vessel lumen. So as for the start part of the high signal intensity, we thought that was the intraplaque hemorrhage because the lesion is located at the vessel wall, and this may cause the total occlusion. And for these scattered and uncontinuous high signal intensity lesions, we thought that was a thrombosis or blood clot because it was in the lumen. So after we discussed with a neurosurgeon, we thought the patient had a chance to go through, and so he did it, and finally we succeed. This is a failure case. In this case, you can see a diffuse high signal intensity lesion over the C1 segment. At first, we thought that was diffuse thrombosis, but when the neurosurgeon used the guide wire to go through it, he couldn't find the true lumen, so we thought that was a dissection. Finally, we gave up. So how to predict the procedure successful by MR-VWI imaging? We still are working on it, but what we are more interested in on these lesions with high signal intensity, they may caused by different etiologies. So we hope there are some new or advanced techniques to differentiate these lesions clearly or accurately. A brief summary. Our initial results show that the patients with short length of internal carotid total occlusion, distal lumen visibility, and high signal intensity in the proximal segment had a higher success rate of recanalization. I think seeing is believing, so 3D MR-VWI images with combined head and neck coil might be useful for the patient selection to perform the endovascular recanalization. And thanks for my operators. Thanks you for your attention.